I'll just tell real quick. Okay. All right. Non-medical piece of advice. I always tell patients when you are losing, like, don't get too excited about, well, don't go buy expensive pants just yet. Your first year of maintenance is not maintenance. Anyway, I will often repeat, like, in 2022, I would have literally never thought anything would be better than, like, the size 12 pants, right? But if you keep losing, you can get in trouble, right? I would highly recommend Poshmark. And here's what you're going to do. Okay. This jacket, which I love, is a horrifically expensive brand. And let me just say, because my husband works for a startup now. Yeah, you should go to Poshmark. Some brands are way undervalued, like versus others. And if you have a brand that you like, like, and it fits you and you know what that size is, you should 100% what you do is enter all your sizes. And then you go on Poshmark and you put in whatever brand. And then you're going to sort low to high. And you will find things like a previously $800 like blazer I got for $44. Anyway, so yeah, you should definitely do that. This is non-medical advice, but whatever. Okay. That's the one on that one. Yeah. Otherwise you'll end up with a whole closet. Well, welcome. We are sort of throwing back today to kind of that first episode as far as like what, like my personal story and things. We'll be revisiting that a little bit and kind of digging more into like, when you have surprises along the way. Remember, like for me at least, I was always practicing as a physician along the way. But when I went back for obesity education, it was actually like really just to help myself. And so, at any rate, looking at that as far as the turning point, when it became, personal, I would say, as far as like challenging like your, beliefs as like a physician and a patient, I think there's just so many times along the way, like you're going to get stuck, right? And so I think like the nice part of having been, sort of a physician who's been through the journey of what this specialty is all about is that, things change, right? And so I would never advocate sort of like one dogmatic sort of a treatment protocol. It's much more like you have to go into this with your eyes open, and this felt like tragedy at the time, mind you, as the patient. But now I understand enough to tell people from the very beginning, it's like, hey, if you're human, you are absolutely going to hit plateaus. And so you go into that knowing that. And in fact, I find one of the most delightful things to do is to just tell the patient up front. And they may not even totally remember is like that worst plateau is going to be, usually 10% loss, right? And so plateaus can be really rough. I know my longest plateau is 4 months. And having started, around, 300, my longest plateau was about 4 months at between 200 and 205. And so I think that what you learn to understand, or I think I would give people much more credit now, is that I think so many physicians are, will sort of negate sometimes like what we say as patients as far as, if someone comes in and I've had this happen and they're almost in tears, right? And they're saying like, well, I get up and like I work out like this much and I'm only having this many calories a day and I'm not losing. I mean, yeah, a lot of the time I know, you know who you are. And I've heard people say it, well, they've got to be eating, but I will tell you, having that insight, of course, intellectually you understand all these things and there's a hormonal control and, elevated insulin levels can prevent loss. Okay. Well, I will tell you, God's honest truth. And I can probably scroll back enough in my Peloton app, and this would be kind of early. What year would that have been? Maybe like, probably 2022, or very late, kind of 2021. No, I got up at 3:45 in the morning. I would actually sleep in a separate bedroom from my husband during the, like work week so that I could get up at 3:45 and then spend 2 hours on a Peloton. Not exaggerating, right? Sometimes I would just do an hour on the bike and then like an hour of strength, but that is what we're doing in terms of like workout kind of, during the day. And I'm still learning, obviously, like kind of more about obesity. I would say I had never explored my own level of insulin resistance at this time. That's a little surprise that's coming later. So I didn't know that, right? I mean, I did that. I like never went over on calories. I went up on calories. I went down on calories. I, went up, and so like you do like all of these. And so I'm just telling you, like what I have learned is that just believe the patient. Okay. Because really that can happen. I'm telling you, you can do everything right. And so this is sort of the basis of, if you're my patient, you understand that, we teach sort of like 4 variables of food, right? And so it's not just the calories, right? It can also be when everyone knows I detest this one because I want to stay up late and party and have fun, right? Not party, but like play Baldur's Gate and, be irresponsible. We call this self-destructive Thursday at my house because it's Friday today. And so, that really cramps my style, but that will ruin everything too. This frequency of eating in terms of like insulin signal, but also the quality. So, after beating my head against a wall, for all of these, like, what did I learn? Because of course, when I say I did these things, it's not like I did them like all at once. It's like, well, we try this and it doesn't work. And so this is the main thing actually that can be so different, like with meds. And it's not that people can't lose weight or get through a plateau without meds. You can. It just takes us a while to figure out what's wrong. And it can be weeks to get enough like feedback from your body on every intervention and decision, right? So what was my answer? Oh, well, I will confess. And if you're wondering, some of this sounds familiar to you as a patient. Yeah, this would be where your plateau checklist comes from. Okay. What's funny to me is when we start practicing a certain way, because I'm like, a few years into this now of like how we practice just now, there's actually starting to be quantitative research that supports some of this. So haha, I was right beforehand. But yeah, so where I had been was, I said I never went over on calories. Let us discuss what I was eating. I am, definitely not a great relationship with food historically. I will say that how I felt internally was I have done all this work and I have lost all this weight and I'm down like, like 100 pounds and I'm doing blah, 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 blah. So if I only get X number of calories a day, I felt like it was my divine right to consume this in Flaming Hot Cheetos and HEB queso. It's wonderful. Really love it. Still love it. And yeah. Anyway, so it turns out like, as a last ditch effort during this plateau, I actually did do, ate clean and darn it, like that it did actually work. So, at every point in a plateau, I think like, there's always like, how do we revisit? And so now we sort of have it down to a very nice, this is what we check and this is what we check. And so, as far as relapses, I don't know necessarily that I had like a relapse. I would say the period at which I'd given notice at my job, like before, I lived here was definitely stressful. This is why I love, if you have an electronic scale, you can follow it as a diet, like a diary. That is the only time I gained significantly and I actually did get over 200 again. And then obviously that long plateau that had been like more than a year prior, to that. And so, I think like what you learn is like, don't panic. And I believe in mantras a little bit, like things that you tell yourself, and you may just repeat the same thing over and over again because the panic and the emotional damage, really from carrying weight, especially as a female in our society, is so kind of powerful, and that you need a way to like dig yourself out of that. And so, I would say what I sort of learned along the way around this is like, you're just constantly wishing, like I wish someone like had told me. And so for us, like at clinic, that's really led to having like a kind of organized, like how we do things, and it's evolved, right? Like, over the last years, I think it's only recently I've actually written like a guidebook where it's like, this is how we're going to do it, like every time, because like this is what works. And so that part is like constantly evolving, as it should. So all the ugly things that people say about science, yeah. If anyone is telling you anything dogmatically, like it has to be this way, just don't listen, because nothing about a human being or any change in the human condition, any journey, I don't care what you're trying to change, the answer will never be 100% or always. If anyone uses language like that, run. Anyway, that will be slightly off topic, but sorry. Anyway, so I would just say also interesting to learn, even when I had come here and this is right before I took, my board certification exam. I was initially very like hesitant to sort of to share with patients because as anyone who has been down this knows, it's like there's a certain frequency which I will recommend like visits as we're starting, initially like monthly, and we're working through a lot of education, and then we kind of like get your feet under you and we'll spread it out a little bit. But actually, I will recommend to everyone that you are seen, at least quarterly your first year of maintenance, because I would rate that as like actually a really fragile time. Like emotionally, it feels like it might all come back. And so that's also something as far as really focusing on comprehensive care. It's not just the meds. It's really like also investigating really what are all of the core issues that you have, right? Probably had I known to even investigate myself, oh, do you have any insulin resistance? Like, why is this not working? I didn't even know that then, right? And I was a doctor and working on learning all this stuff. Probably if I had gone back and like known that, I might have gotten through that plateau a lot faster. Now we know up front to look. And so that's definitely something, that you begin to integrate. Like it's just constant learning and constant changing and making everything better all the time is super, important. As far as, let's see, growth and learning, what's changed since I've started, oh gosh, like about everything. And so as far as, perspective on all of this, it's just, mind blowing to me, the wealth of information that is out there. I went to, gosh, I started going to conferences in maybe 2021. And I know I went to the Obesity Society. It's like, oh, Obesity Week. Awesome. And that would have been 2022. And so just we're constantly learning more. And so as far as like how my perspective has changed, you know, I think, I'm much more probably confrontational, like in a good way, as far as like obesity, like, being a disease. Like when people say, what do you mean? Like a disease? Like, if you define this as far as, abnormal physiologic state, yes, right? Like you can quantify this. You see it like on a page. And also the people who are resistant to this, like if it's not a disease, how come you can give people meds and it just like, obviously something was wrong. Okay. And so, yeah, I don't tolerate really like that being said around me, at all. As far as for, health, I think my perspective as far as the value of the journey in terms of has probably broadened somewhat in terms of not looking at just the treatment of obesity as like it's not just getting rid of a negative, right? As far as I decrease this health risk, there's like so much more positive, and the weight is only part of it. On the getting rid of a negative part, yeah, I'm going to like decrease fat around your liver. I can measure how far your visceral fat has gone down. I can show you like the muscle you've either grown or held onto, like all of that. But I would rate as intensely more powerful than that as far as health. And I just don't mean like health is like a non-negative. It's like really telling someone now, like I'm 51, right? Oh, no, I'm not. I'm about to be 51. Sorry. I was rounding. But anyway, I would now, knowing what I know and knowing how we get here and the situation that I'm in metabolically, yeah, because nobody told me at 35, oh, hey, by the way, 35-year-old female, just, be aware, if you're not having adequate protein intake, as a bolus at least twice a day, you're going to start losing 1 to 3% of your muscle mass per year. And by the way, this is why your metabolic rate goes down. And hey, by the time you like get older, you're going to miss that. So like, it's too late for me, but for my patients that are younger, how awesome. Like we get to like actually like prevent this. So yeah, how it's changed, certainly my practice as far as on the preventative side is, it's not just dietary changes that can help you with like loss or speak to or treat, with diet, your specific metabolic challenge. It's prevention. We can hold on to this muscle mass. We can help prop up your metabolic rate. Maybe we won't take such a hit of metabolic adaptation when we've lost. And so all of that has really changed. I think, it's such a bright and exciting time here as far as, we're here at late or sort of late 2025. there are so many drugs in the pipeline. So, oh gosh, you've got orforglipron, you've got the higher dose sort of Rybelsus variation is probably going to come out 2026. Retatrutide is also maybe 2026. And cagrilintide, these are all better. And so everything about this, because we have understood the physiology so much, all of these things are getting better. And that's really the hopeful thing also on cost for me as far as this is constantly evolving, right? And so I will tell you 100%, if you are going to a compounder or any online source, if you are paying if you have normal commercial insurance and you're paying, over, well, even 100 a month, something's wrong. Okay. So 100%, let's come talk to us. There are ways through this. You should not be lowering yourself and taking some, compounded crap where there's actually studies out there where the active ingredient isn't even in a fair amount of this stuff. Oh no, we can get you name brand things and there are lots of opportunities. Why? Because the diagnosis, right, codes or FDA approved indications. So for instance, Wegovy now, we can prescribe that for fatty liver, right? Metabolic associated steatohepatitis, right? MASH. Zepbound is approved for obstructive sleep apnea. And so there are a lot of things that we can get into. I think the constant evolution of medicine and what we're learning is just staggering. And I would expect that to continue. And so that's definitely really changed a lot of practice. As far as, lessons and things we get from patients is going to be always hammering home. It's the way with which we approach things is sort of the same, but every patient's journey is different. And patients will always keep sort of re-emphasizing it doesn't matter what was working so far. There's always going to be the next patient. We're oh, we had to circle back to this. And so patients are always, helping you learn, or me learn, as well. It's this worked for this amount of time. Okay, now we've got stress at work. We maybe need to use something else. And so we are constantly learning and shifting all of the time. As far as, on the science end, there's a lot of things that I've learned, from my own journey, in practice and we definitely, integrate and use all of that. And data-wise, this has been amazing because it is incredibly normal, ordinary, and expected in my practice for people to be able to lose and maintain, well over 40%, which is way beyond what's published. And I would say why? Well, because we do it we don't ignore this sort of idea that if you struggle with what is now being called an obesity phenotype of hungry brain, if you struggle here, nothing else works that great. And I knew that as a cheat code for my own journey, because the first time I ever tried, a GLP, I was and my sister Deborah will attest to this because I told her that I'm I think it was Manjaro, might have been Manjaro, I don't remember. But I had tried it, out of curiosity, and I was I don't think this does anything. Actually said that, okay? And I was I don't get, I always practiced by guidelines, right? That was not kind of my personal experience with it, but I'd seen patients do well with it. So obviously I still prescribed everything, per guidelines and as, recommended. But what I'm so thankful for is the, knowing from personal experience. It's different to know it from a book, right? You can know it from a book, but if you've ever, I'm so thankful I did have that experience because now I get it, right? And so I will tell you, look, everything works, right? We just have to find what is going to work for you right now, maybe during a plateau, and really what is sustainable in the long term. And so, sure, if you're super stubborn and you've got a contraindication or you're opposed to med, we can life by the checklist. It will work, right? Stubborn in a good way. And that will work. It's just this constant shifting. If we get to the end of a sort of medications dosage range, we'll switch to something else, make it fresh, do pulse dosing, right? So I'm stealing things sort of from other kind of studies and such all the time. And so pulse dosing is actually published in kind of a couple other areas, but we find that it also can be effective. And that's another great strategy sometimes for getting through a plateau. So um, it's always good to be reading. It's always good to be reading like outside of your area. And you can sometimes, use that in others. So we understand patients lose way more with metformin and GLP. Well, if they have trouble tolerating that, hey, over in the PCOS arena, there's a published study that shows non-inferiority between really high dose inositol and metformin. So would that be an option? Because if this patient's not progressing and they've got a crazy high insulin level, oh, I really want to fix that, or we're never going to lose as much as we could have, right? And so I do sort of beg, borrow, steal, and kind of take things from other areas. And that is like a constant kind of thing. So as far as, let's see, number 4, common misconceptions that you've faced. So what people get wrong about doctors and obesity medicine, that I'm just going to prescribe you as something and give you a pat on the back out of the door. Now, actually, I have had patients tell me that has 100% happened to them, but like absolutely not. Okay. I mean, if you want that, go to a med spa. I'm sure someone will prescribe you, I don't know what it is, some compounded whatever. If that's what you want, fine. The treatment of obesity medicine properly done, I mean, this is not that. I want you to have a solution for the rest of your life. I would love it if by the end of your journey, you know everything I know about this. And so that when you hit stumbling blocks, in your maintenance and along your journey, which is going to continue for the rest of your life because you're going to have this forever. I want you to be able to seamlessly like go down that checklist and know where to start for what to change to make things better or to fix it. And so, no, the concept that we're just out there like writing like meds, that's terrible. It's also very frustrating on my end if someone never talked to a patient and they're just like, oh, just here. I'm like, oh my gosh, all right. Like, what do GLP meds do? Right? I mean, if you're talking about massively oversimplified long-term regulation of weight, you kind of got insulin on one side telling you're going to gain and you've got leptin on the other. If we hadn't carried weight for a long time and we got all our intact signaling, if we're carrying excess fat mass, leptin goes up, and leptin should, go up here and have some GLP in the brain, tell you you're not hungry. And most of us are culturally taught to totally ignore this, right? And so GLP medications should make you less physically hungry, right? So before you write a prescription for a patient to help them lose weight, maybe you should ask, do you ever eat when you're not hungry? And obviously, if someone straight up tells you no, there's already a problem because 100% we all do this. Things taste good, right? And sometimes you do for a certain reason. I'm going on a flight. I'm not going to have access to, whatever it is. We all do this. The point is, how much and to what extent? Do you feel bad about it afterwards? I mean, that gets into sort of binge and reward motivated eating, right? If you have a really struggle at night, I almost can't stop. I don't struggle during the day. I get home at night. I really have trouble stopping. Night eating syndrome, right? And so those are what would be effective for that medication, that patient would not necessarily be the same thing. And a GLP actually would not be the right place to start for that patient. Not that it can't ever be productive. It's just if you ever start a medication, and God forbid an expensive one, and you aren't having this, borderline spiritual experience with incredible food noise reduction and hunger reduction, which should be proportionally higher the farther your weight is from goal, something is wrong. And so you should not just go up on that med. You should reinvestigate. Hey, are we ever eating when we're not hungry? Maybe we should try this other medication. See if, if we interfere in this reward pathway, then all of a sudden, does this GLP work like magic? Okay, that's why, right? What is the insulin level? Do you have a competitive resistance to this med that we're not controlling? Like all of these things should be looked at first. And so the answer is not, and this is just a definition of insanity, right? I give you the expensive med, it doesn't work, so we will do more of the thing that didn't work. Like that, common sense, right? And so, I would just say, to all things, let it be determined by that individual patient's body. The body's never going to lie to you. If we are progressing, what we are doing is the right answer. If we're not, it's not. And we revisit that. But we never assume that we know the right answer going in. And if something that should work is not, we do not just persist with that, we investigate and we figure out why it doesn't work, and then we fix that. And so always be open, never assume that you know anything. These are constantly things I'm telling myself. As far as, misconceptions I've faced, oh gosh. Now it's rough because sometimes I almost feel bad for my patients who, I actually had a new patient today. Not, it's somebody else's patient, but a weight loss, consultation. So I'm just, to help with that. And I almost feel bad if they don't know that I've lost weight before. I'm like fairly quick to disclose that, because how I felt, this cuts both ways, right? As the physician, in that I do feel like so many physicians are hesitant to even mention weight if we struggle with it ourselves. That's how I felt before. I was like, good grief, like my BMI is 44. Why on earth would I be saying like, how could I even say that to them? And I think how we need to respond to that as physicians is just be like, one, I am also human, right? And so, and just be like, look, don't talk about it as me talking at you, just be like, look, I struggle with this as well. And hey, these are the recommendations, and this is like where we can all get started. Right. And so, like, work on it. If you know it's the right answer, then, we should be doing it too. Right. And so I do think that there is, a little bit of personal responsibility there, but like life is hard. And so, and also, I think to look at someone, you also don't know the answer. Just because someone appears overweight, that does not mean that they are not killing it in the gym like a couple hours a day. You don't know. You know nothing based on like how someone appears, right? And I'm sure someone, when they saw me around, I don't know, 220 or whatever, it's like, I may not have looked that, but I was like, you don't know where they are on their journey. So don't judge. Nobody should be judging anyone else like by their, their appearance, for good or for bad, right? Because just because someone looks thin, put them on a body comp scanner. That doesn't mean they don't have 40% body fat or a lot of visceral fat. And so, let's be honest, right? Like I have hardly any visceral fat. My body fat's like, okay. And so, but I need to work on building muscle mass, and I am. But the cool thing is, like, we've all got something to work on. So nobody's perfect. I think it is hard as a physician if you are struggling, or if you are overweight. It's uncomfortable to say things. I think if you are a physician who appears like you might not, have an issue with weight, that's also rough, right? Because it's like people make so many assumptions. Just because someone looks thin doesn't mean that they aren't working really hard at that. Regardless of what, like I have class 3 obesity for the rest of my life. I do work at it. I work at it every day. And so I think we can all be nicer to each other by like trying not to like make those assumptions. I think all of us need some place to turn to that there is, continued support. I think there's such value and like comfort in knowing like, oh gosh, like I wasn't the crazy one. Like I'm not alone here. And honestly, that's like half the reason to put this stuff out there is like, this like glossy stuff from like magazines or like, the model like walking wherever. It's like, oh, please. So fake. Right. And so no, please, like we've all got something to like work on. No one's perfect if it looks that way. That's really cool, like lighting and photos, but it's not that way. I promise. Doesn't matter who we are. And so, yeah, I just think, assumptions being like, we're just going to write a med. I would never do such a thing. And I think the true practice of obesity medicine is so much about building the patient up and getting you set up to where you can like fly free, hopefully without anything, but, be open to it if you need it. And so, as far as, I think another common misperception is like sometimes even on the patient end that they're going to come in, and I'm going to write you a med and you're like done and you'll handle this yourself. Like, again, that is a med spa. And so maybe, or wherever, it's not me. And so I actually got a message from a patient today. It's like, I'm very clear. It's like, this is like kind of the protocol. We'll see you like a lot up front. It is just like I would argue it's too, for weighing very infrequently, that is really demoralizing because you did not get timely feedback, and you might be finding out about your, progress or lack thereof way after the fact. And so, by the same token, I don't, unless you're in your first year of maintenance, I don't want to see you in 3 months. Like, what? Like, no, we're getting started here. Like, we space you out to like every other month when you're like in what I refer to as the wash, rinse, repeat phase of weight loss, when things are going well. We do not like have one visit and sail off into the sunset. And so all of us need continued support. And to act like we don't, or that we can do this very infrequently, is really disrespectful of really the severity and, seriousness of this disease. Like if someone kind of thinks that, it's like you didn't get a lot of what we said, in that this has to be an area of focus. And honestly, if you can't do that, that's okay. Great. Go through some videos, begin working on it yourself. If we don't have time to really be regular in that, to have properly supervised care with enough like education and appropriate management, maybe it isn't the time, and that's okay. It's okay to pause things, and then our goal shifts for a while, maybe to maintenance, but all of us are going to need some amount of continued support. And it's, in my opinion, inappropriate to just, prescribe and give you a pat on the back and see, like, I'm not going to say I would never do that. Let's say someone's really experienced and they've like done all this before, maybe like, I don't know, a longtime patient, and they've done this before, maybe got a little, maybe there would be some exception, but realistically, probably not. Especially if we're like early in the progress. And so I think we really need to normalize every single one of us needs a lot of support up front, and all of us need ongoing support. And whether that is like kind of through your community or what, I mean, it's got to happen, because by the nature of the disease and its chronicity, it's, if you take your eye off the prize, and 100%, it will come marching back. And all data shows this. We are better now at losing. We are no better at maintaining. And that's the real trick. And we want to plan for that. And we don't just let everyone fly free and, maybe in maintenance, see a quarterly, and then we'll, maybe even like less after that, but certainly not what we're actively trying to lose. As far as number 5, real life habits that work. There's about 1 million. And so, what do I like? So I'm in maintenance, right? I'm in year 3 of maintenance, and I have a busy job. All this is preceding. Here's what works for me now. This is in no way a directive, like this is what you should do. To me, in everything dietary, you've got to, same thing as always, you accept everything will work for a while. And when, not if, but when it stops working, that's when we make changes. And so, what I tend to do now is, on the maintenance end, what is called partial meal replacement. There's a lot of data on this. You've got longitudinal studies that are up to a decade. Some people find this when was that? Obesity Medicine Association, a conference, which was in April. I went to the sort of pre-conference. I think that was focused on maybe nutrition, or I can't even remember, but I know it was a lecture about nutrition. So you have this incredibly qualified nutritionist, just got a PhD, and she presents all this data, and she's going through sort of all of these nutritional options. There's like full meal replacement, that's like a limited time, and she's going over this, and she goes over partial meal replacement and all this data, and she talked about it like as a maintenance strategy. And basically how, like, even if you look at these people over years and years, if they're, as long as they're having at least one balanced meal a day, nutritionally actually superior, right, than free feeding, you would not believe the level of pushback that this woman got at a medical conference. And she's the expert, right? She is, I think she might be an MD, PhD, it might have been, and she she had an MD and an RD, right? So also a registered dietitian. And I think, and so this eminently qualified, person presenting data, this is not like we get to have an opinion about it. It's data. So this is what the evidence shows. Okay. And you just get a bunch of, and this is the embarrassing part. I hope they weren't, but maybe they were physicians, but, who are saying, but what about But shouldn't they like have to eat? And like, I'm like, why? She literally just showed you years and years of data and multiple studies, like, and, a systematic review and meta-analysis that says like, no, for partial meal replacement. So if a patient chooses to do this, is it nutritionally okay? Yes. So how about as the clinician, you know, why would you ever resist that? If this is what the evidence shows, my job is not to have an opinion about it. It's my job is to say, be open to it. And like, this is what the evidence shows. And so I was like really concerned by that. And that there's actually someone who's practicing, who seemed so resistant to this concept. And to me, it's like, look, you're always going to hit a plateau. Be open to change. So all that to say, yeah, on a daily basis, it's very common. I would say a typical pattern, and this is me, right? Am I going to stick to anything like 100% all the time? Probably not. But I would say the default sort of pattern would be partial meal replacement. So morning, I usually have a Premier Protein with a Fortibone in it, which is the Algae Cow Complete Collagen Supplement, because I'm a postmenopausal female and my bone density, my hips was slightly low. And there's evidence for a Fortibone and some bone density. It also has Verisol in it, which is good for, at least by some data, some of the bioactive collagens that can be good for skin. And so I add that to my Premier. And so that takes it up to 40 grams of protein because, again, over 50, you want a bolus of at least, 40 grams of protein at a time, at least twice a day. Why? Because the real data says actually 30 grams, but we know that as you age, you're not as good at absorbing. So I just usually tell patients to kind of bump that up by a little. So that's what I do. And my husband is amazing because usually while I am jamming out to preferably 80s alternative music while getting ready, he will often, God bless him, will actually make that for me with a little bit of ice and some sprinkles of cinnamon. And that's a perfect morning. Because honestly, I'm not really hungry in the morning. And as I tell patients, like, but if I don't at least have that, odds that I'm going to complete my protein journey for the day are like low. And this is so important to maintaining muscle mass, annoying. Oh, and I do put creatine in that. More on that later as far as the actual calculations for postmenopausal females, as far as muscle preservation, a little bit higher than other recommendations. But at any rate, so I do that in the morning, ideally during lunch, because I have these actually delivered to work, but I've slacked on that lately. Normally, I will order from HEB to be delivered to work the Core Power 42, so that I would have that. Recently, Murtis, who is my nurse practitioner, she got the blueberry lemonade. It's a fizzy drink. They sell it at Costco. Amazing stats. It's got 130 calories and 30 grams of protein. So recently I've been having that because usually I'm kind of busy, or I will bleeding heart book people through lunch. So sometimes I do forget on that, and that's not great because then I get hangry like 2, 3 p.m. And then it's like an emergency. So we try to avoid that, but constant work in progress myself. And so that's kind of like what's working for me now. And then I like to have a relaxed dinner. Okay. So what's going on with me? If you feel like that doesn't sound like that much food, oh no, it's that I want it for dinner. Okay. In residency, when chronic sleep deprivation, they would talk about this concept of sleep banking, right? I've often think of partial meal replacement as sort of calorie banking. What I like about partial meal replacement is like, if I've done everything right, postmenopausal female, you can kind of feel like, your diet is like a job, I need to have this, like creatine and my, whatever. And so to me, I like this because I've engaged in what I refer to as objective oriented eating. I've met all my little check boxes by the end of the day, and I don't want to mess with this at night. Okay. I don't want to worry about this at the most like kind of social meal, or if a friend asks me to go out to dinner, I don't want to worry about it or like, worry a lot about tracking. Remember when I told you tracking works? Yeah, I did that. Right. Tracking and regular weighing, that is how I, really lost my initial like 130. And so, oh no, I did that and it does get old. Incredibly valuable tool to bring back as needed. But so I maybe still have like a little bit of aversion there, even as though it's so evidence supported. And I do it when things start like kind of like going up or I get off track. But as a general rule, I want to live free. Like I really want to live free. So I engage in my surveillance weighing. I'm actually not usually that hungry during the day if I'm taking my metformin, because I am like very insulin resistant. This was a very sad finding when a rep brought us the Libre glucose sensors. And I just tried one literally only so that I would know kind of how to counsel a patient or be able to tell them like accurately about it. And then I found out some unpleasant things. And so I start seeing, my glucoses were, it was like not stable. This is like after like I've lost weight and in maintenance, right? And so I start freaking out because like my blood sugar was incredibly high, like after eating, like my fasting sugars were like 130s to 140s. If you're a doctor, you know what that means. And I was sort of in denial and it didn't really, I didn't want to entertain that. So bottom line is I'm wearing this continuous glucose monitor and my predicted A1C is like going up by 0.1 every day. And I'm like, So I started taking metformin, but I actually found something really interesting. And I actually used that in combination with a continuous glucose monitor just to where things were evened out, is that when I started that, unbelievably less hungry. And so I would say that at least for me, and again, everyone's different, my sort of primary drug of maintenance, in addition to, controlling my baseline ADD and binge eating disorder, which I will probably, have forever, but is much better and under control now, is really metformin. Because I notice on the days I don't take that, oh no, like it's on, like I want stuff all day. And I think the one day I actually forgot to take my metformin in the morning, and I was just, oh my gosh, I was like so hungry. And I remember Myrta said in clinic, she's like, I've never seen you eat like this. And so, I take my metformin, and then actually I'm not kind of super hungry until the afternoon, and hopefully we've prevented that with kind of the protein shake. And so for me, this is a good and sustainable pattern, because also the situation I'm in is I've lost more than 50% of body weight. I am old, not old. Wherever, postmenopausal female. And so just given that and accounting for my metabolic adaptation, like, especially if it's a day where I'm not, going to have a lot of time to exercise, my metabolic rate is really low, but I don't want to like not eat like the good stuff or be free to go out to dinner with friends. And so therefore I really like partial meal replacement because it kind of gets everything out of the day for me. Also for someone who's insulin resistant like me, I know I'm not going to be popping or, blood sugars or raising insulin. That might make it more difficult to lose for someone who we're going to lose. But for me, decent pattern for maintenance. I get my protein requirements out of the day. I eat mindfully, intuitively at dinner. Nothing is off the table. And I keep doing surveillance weighing. Weekends are a whole different story. It's not probably. I know I do not get adequate protein intake on the weekends. Yeah, because I just weekends I loosen up. So we understand actually that like lactose or milk sugars have a little bit more of will have more of an effect on, blood sugar and insulin resistance. But this is where I will tell you like, oh no, I don't want the coffee with I don't usually have coffee during the week. But what I really like, this is the best coffee ever. You want the best coffee ever? Great. You need an espresso, and then you're going to get what is that? I don't know. It's the one that's made, Bianco Leggero. It's the one that's made to go in milk. Then you're going to get your HEB Mootopia, no lactose and a little bit more protein. And you're going to do the frothing in that. And then you're going to put, and then while it's frothing, you should get vanilla bean little like kind of sprinkles and then put it in there. Oh, it makes your milk taste the foam like it's like vanilla. Is so good. And then your coffee, like as it's like kind of brewing, you're going to put between 1/2 and 1 teaspoon of honey. Is this real sugar? Yes. But there's a magical interaction between the taste of honey and like coffee. Oh, it's great. Anyway, and then you're going to put like a little bit of cinnamon in it, and then you dump your like the frothed milk in, and that is like the best coffee ever. And every time you froth, it's about 1/2 cup. So, 1 or 2 of those per day, like on the weekend. And I don't really worry about stuff on the weekend. I'm more relaxed, eat mindfully and intuitively. And there is a little drift up on the weekends, but like I am in maintenance, right? As far as, other kind of routines, it's always shifted. Inevitably things will stop working. And so I'm just always open to change, but that's just me. It is not a prescription or advice for anyone else. As far as, medication, we kind of talked about cornerstones are for me going to be, metformin as far as the insulin resistance. And then I'm kind of controlling the other mental like health kind of support. I mean, I am lucky because I work in a place with two fantastic coworkers who have also lost an incredible amount of weight. And that's Murtis, our nurse practitioner, and Jade, who's a physician assistant. And like, so there's always this level of support, right? Almost everyone that works in our clinic has like lost a ton and is in maintenance. And so there's always support and encouragement there. And so that I'm really thankful for. As far as the exercise right now, my daughter's about to get married in, is it like 2 weeks and a day? And so I've been a little all over the map in terms of exercise recently. I've started going to Club Pilates, which I really, really like, and playing racquetball once a week with a friend and doing some rock climbing. And Lazy River doesn't count as exercise, but it's amazing. Everyone should go. If you're in Lubbock and you've never done that, so amazing. Definitely was not there when I was at Tech. Okay. So as far as like what I wish I knew, way back when, it's got to be metabolic adaptation. Chief number one is that nobody ever tells you up front what a penalty there is to your metabolic rate from a lot of loss. And so, that I think is something why we always go over that first visit. And so, again, I would just say, this is what I'm doing. And I am 100% totally open to changing that at the drop of a hat if I ever get bored with it or just feel like it or like hit a plateau or gain. And so our goal is to give you options, right? If I got sick of protein shakes, which I've already done, then we're going to give you a list of, whole food options that have similar stats. Because do I care that it's in a shake? No. We just want you to have the protein, right? I will tell you, a patient told me one of the most amazing things recently. Greek yogurt, already low cal. You can get the no added sugar, the plain. There is a brand of protein powder. I think it's called Cellucor, C4, whatever. They make a Reese's one, okay? Reese's, like the inside of a Reese's cup. So you're going to mix that like with your Greek yogurt. And then you are going to, I do not know why anyone would use semi-sweet or dark chocolate. Gross. But if you're me, then you can just like a little bit of like milk chocolate, like you can put that over the top. It's like amazing. Better than a Reese's cup. You've got all your protein. You can have that, right? It doesn't have to be a protein shake. Who cares? If you don't like it, do something else. A patient also recently told me that same brand, which they sell at Target, that they have a Fruity Pebbles flavor, which I can't even, that's amazing. I love Fruity Pebbles. So I might get that. Anyway, but yeah, always keep changing, right? As far as like how, my journey or anything feels the AthenaMD, it's like, I think having been through it, it's like nothing, there's nothing better than knowing that you can help someone else, because it's like, I've lived it all, right? I know what that feels like as far as just the constant discrimination and also internalized bias, right? And feeling so, I think there were times in my life where I really felt like it's almost like every other waking thought was about like my like awful situation with my weight. And like, I felt like it was such an imposition to me to even go to things, because I just made something that was so like horrible to look at for other people. And so that I was doing them a kindness, like by not going. And so there are, friends I have today. Another one's actually another physician in town who for years would, invite me to a Christmas party. I never went because I felt like unworthy. Like, I shouldn't go and like ruin the event with all the beautiful people by like being there because of my weight. And so no, I don't get invited anymore. That's okay. But the point is, it's not them. A large part of that was me and not people who are your friends. And so I will say it does behoove all of us who are on this journey to examine, was it really them or was this me? Like the society on its own does a lot that we probably imbibe and accept as a condemnation of ourselves, and you shouldn't. And I have lots to say there, but having lived on one side of it, I think nothing makes me more sympathetic than just understanding like what that pain is and where someone's been and being uncomfortable when just being so wondering if the airline seatbelt is like going to fit, or feeling so bad for your children because everyone else's mom is pretty and thin. And so it's just, having lived that, I just like always want the best for your patient. It's not a look, or I want you actually to know that your body can be what you want it to be, whatever that is. I don't care about the size or what, it's like we try to change that conversation to like, you are doing this for health and for you, and screw those other people. You know who they are. And growing past that. And that is why, honestly, it's not just the evidence actually about the scale. I do often tell people, like, just by the data, regular surveillance weighing, this is actually one of the most cost effective and actually just truly effective, not just cost effective, reliable strategies for both weight maintenance and loss. And I get it. I feel you when you say like, you don't want to get on the scale. And you know what? My job is to give you all the information. I tell patients all the time, I want you to know what I know. You have to cafeteria this into something that you can make work forever in your life. But by the data, it's like, yeah, we're better at losing. We're not better at maintaining. And oh, by the way, even if patients had surgery, if they're not regularly weighing, statistics are they're going to regain really significantly, if not everything, within 5 years. And so, and there was that study in, I think it's like November 2023, that actually was able to quantify it. There's a linear relationship. So I will let you know by the data weighing, it was once a week was worth 3% loss. Okay. And then it was about around 2 out of every 3 days was 10% loss. And people, that have lost well over 100, I weigh pretty much every day, unless I forget. But why else do I care? It's not the efficacy even, right? It's the fact that please realize you are living in a world that is telling you that there is something wrong with you and is judging you and is doing all of these things, making you feel unworthy, because more than half of American women wear over a size 14. But what is the highest size sold by most corporations who have a duty to make a profit, mind you? They're open and they're selling women's clothes, and they've already decided, yeah, I'm not going to sell to at least half of my potential clientele. What does that say to you? Okay. And so this is what you've grown up with, right? Okay. And so, I don't want anyone to see the scale as a piece of trauma. This is society is telling you that you need to do all of this. Like, we're judging you by this. Oh, okay. But like, don't look. Okay. So change it, but don't look at the thing that we want you to. Okay. Also, we have enough issues with like women's health in our country right now. I don't want any woman to ever feel like you shouldn't know or have a right to know or be able to know like what is going on with your own body. I would rather, food for thought, like reclaim this. I would argue now that sometimes the higher value in surveillance weighing is not just to make sure that we are engaging in appropriate interventions or to make sure that we're engaging in surveillance weighing so that we do not regain. It is actually to reclaim this and begin to see it actually through desensitization of this repeated exposure, that this is not a judgment on your self-worth, that this is rather a piece of data. Because the definition of insanity is to keep doing the same thing and expect a different result. Well, how would you know if what you're doing is working, right? If you don't have any feedback. And granted, for those of us who have struggled, I'm willing to meet like anywhere. I'm just saying, like, there are reams of evidence to support this. This is actually the most supported intervention in habit. And I would argue the desensitization in this regard is valuable. And also, what do we learn, right? It's that your weight's not even the same day to day. In fact, I often assign as homework for patients to to weigh the last thing before bed and then to weigh again in the morning. Why? To learn. All you did was breathe and maybe go to the bathroom and you're down like a couple pounds. So the concept that you even have a weight is a bunch of BS in the first place. We're just using this as a dispassionate proxy to see like if we need to change what we're doing. That's it. And so I know that I've like completely gone off, but it's like, as far as like being passionate about it, I hate the position that we have put so many people in. I hate that our society is like so unwelcoming. I hate that this is presented as like a moral failing. That is a bunch of like, just, I really want to swear. And I feel like I'd be so more satisfied if I did swear, but it's a bunch of BS. Okay. That is what, I mean, no. Like, we understand this as look at the labs, look at what is happening. Like, this is from every bit of logic that could ever be applied. You know, tens of millions of people did not all begin to experience a moral failing all at the same time around 1980 and start gaining. No, you know that something's going on. And this also feeds on itself because we know that there are generational and epigenetic effects. So like, no. This is a disease. This is a physiologic abnormality. We can get you through it and like treat this. And you should be honestly angry that anyone says anything else. Also, let's like review other things, right? You know, as far as the amount of weight bias in our society is so, well, why would you treat it? Like, what if they like have to take the medication the rest of their life? I'm sorry. If someone has elevated blood pressure and I give them lisinopril and their blood pressure is good, so now we should take it away. And the thing is, we're doing better than that with weight maintenance, right? I hope all of you can like maintain, but just the cognitive dissonance in what is allowed to be said about obesity as a disease versus every other disease. I mean, we sure can't cover Viagra forever, and you definitely don't need, I mean, I understand, but you know, to be having sex. Are you kidding me? Like, but we'll cover Viagra. Oh, but no. Oh, and then is that bound for weight loss? Oh, no. But for obstructive sleep apnea? Yes. Okay. What causes obstructive sleep? Also, I will point out here that obesity disproportionately affects women. They won't cover it for that. And obstructive sleep apnea, men, but we will. Just more food for thought. At any rate, I will try to calm down now. And, you know, I think that having been through all of this, it definitely makes us much more cognizant and aware of what the patient is going through and really where those push points can be in terms of what we need to change when someone is not progressing. And we turn over every stone and really work on it like as a team and together. And we are constantly, Murtis and Jade and I, talking about this together and patients and like what we can do and how we got something improved and all of this. And I love where we are at, that we are also in a system where we were able to work in a concerted fashion with, you know, a manufacturer like Novo Nordisk and the rep and our pharmacy program to get incredible discounts on meds for patients. And so I think that is, you know, that keeps, I think, all of us like really, you know, grounded and like passionate about this. I think our experience, and that this is probably over 90% of what I do daily over years, has really led to a lot of insight. You know, we've been practicing the way that I practice in terms of, you know, hungry brain, fix that, you know, remove any metabolic inhibition to loss, and then, you know, begin with recovery of normal hunger signaling or the hungry gut to treat that. That's how I've been practicing for years. The first time I saw research presented on it was actually this April at Obesity Medicine Association. And so it's actually interesting in that we've already been doing all that and has enabled us to, or me, I guess, you know, to write up as far as this is how we were going to go through things. This is our thought process, and to begin to really standardize kind of treatment protocols. As far as a future patient, if you're ever considering that, what are you going to expect? First visit is a lot of history. We're going to talk a lot about obesity physiology, insulin, leptin, metabolic adaptation. We're going to go over your goals, really try to characterize whether, you know, we have what your obesity phenotype is. Do we have a problem with hungry brain or hungry gut? And what order are we going to treat in? We are going to overturn or look under every little rock to see does anything look like diabetes or insulin resistance? Do you have obstructive sleep apnea? Do you have fatty liver? We're going to get a body composition scan. And we're going to set some goals, and then we're going to see you about every month for 3 or 4 months. And we're going to see you every other month till you get to goal. And your first year of maintenance, we'll see you quarterly. And there is a little kind of educational topic protocol for visits 1, 2, 3, 4, 5, 6. And then we, kind of start like just revisiting like as needed. But yeah, I mean, that is the order we do things in. And we revisit like everything like as needed. And so that's what you can expect, if you ever come in. And so, I would say, for anyone who's like starting out is just, some of this you can walk through on your own, right? I mean, reflect. I think the easiest place to start are the simplest things. It's like for some patients, honestly, it was revelatory to just inform them that your body has normal rate regulatory mechanisms. What if you could actually listen to your own body and that was enough? I mean, honestly, some patients, I feel like some of us, I am an eldest daughter, there's lots of funny little memes about that. And yet, the good girl, right? That you always want to do what you should. Sometimes just giving a patient the permission, like stop, like forget about the words breakfast, lunch, dinner, just eat when you're hungry. Literally, some people make it to goal just with that. That's it. Surveillance weighing, mindful and intuitive eating, that's where everyone like should start. And so I would say reflect on that for you. Reflect on your relationship with food. Is this okay? Is food just food? Is it nutrition? Is it food? And food is always, the answer is it's always just more, but is it in an unhealthy way more? Are we ever hiding how much we eat from, just reflect. What are your push points? What would you potentially need to work on? Sometimes, honestly, just being aware and like beginning is like enough. And then we definitely plan on putting up like every educational topic that we cover with patients. So like the first 4 or 5 that we always cover on an initial visit, as far as, obesity physiology, obesity phenotype, surveillance weighing, mindful and intuitive eating. We always cover those like first, kind of weight visit, in addition to your history and everything. And so we really plan on putting all of this up as far as just individually so that we all have an opportunity to revisit that. Like, wait, what did she say? Because I feel it the same too, right? The second my doctor closes the click, that's when we forget everything, right? And so, yeah, because we're all human. And so I would just say, definitely like follow along, right? Hopefully more of these things should be out there and available in a more organized fashion. We look to like hopefully get some of that up on the website as well. And so definitely subscribe, right? If you know someone who's struggling, pass it along. And I have this memorized now from, wait, is it YouTube? The like, comment, subscribe. Yeah. Is that right? Yeah. Okay. Follow. Oh, like maybe it doesn't matter. Whatever. Do whatever. That'd be great. See you next time.